Hello, can everyone hear me? Yes, I think you can. So, good morning, or afternoon. My name is Ryan Wereski, one of the clinical research fellows at the University of Edinburgh who works in Professor Mill's group. And today I'll be presenting some work that we have done on the role of troponin in the chronic coronary syndrome with colleagues from Imperial College in London. My only disclosure is here. So if we think about the diagnosis of angina, it really has changed very little in the past 200 years, since first being described by William Heberden in his paper in The Lancet, Some Disorder of the Breast. And although physicians such as Robert Bruce developed the Bruce protocol in the 1960s, all progression in diagnostic techniques have really been focused on the identification of ischemia rather than the identification of patients who are at highest risk of complication. And this is actually despite our developments in our knowledge and our understanding of the physiology and anatomy of coronary disease. Now, with that being said, recently several trials, including Courage, Barry 2D, and ischemia, which I'm sure you're all aware of, have challenged the way that tests for inducible ischemia are used and disrupted decades-old practice of using ischemia to inform management decisions. But really, without an alternative way to risk stratify people, it's become increasingly challenging for clinicians to decide when revascularization might be the best option over medical therapy alone. And many people are now asking, what about biomarkers in stable angina or biomarkers in chronic coronary syndrome? Well, in patients with acute coronary syndromes, we know that biomarkers have a well-recognized and established role in risk stratification and diagnosis, but they're less so used in chronic coronary syndromes. That's despite the fact that research in this area is developing, and we actually know that in patients with stable angina, troponin levels are associated with high-risk plaque features. And we also know that if you stress patients with exercise who've got moderate to severe ischemia, troponin levels also rise. But one major barrier to the rollout of biomarkers in chronic coronary syndromes is a lack of a mechanistic explanation, and it seems a major hurdle. And actually, the phenomenon of troponin release after exercise can actually be seen in people who are healthy without ischemic heart disease as well, suggesting that troponin release is purely not mediated by ischemia. So to try and determine a potential role of troponin in chronic coronary syndrome, we conducted a sub-study of the Orbiter trial, and this we aimed to evaluate how troponin levels changed before and after exercise, and also before and after revascularization. Now, for those who are not familiar with Orbiter, it was a randomized control trial of 200 patients who were known to have severe coronary disease. These patients were then randomized to intervention with PCI or a sham procedure. Now, we measure troponins both before and after exercise, both before and after intervention. So in total, we had 198 patients who were included in this analysis, and you can see that they had a high proportion of typical cardiovascular risk factors. We can also see that these patients were what some would call high risk, with the majority having stenosis in the LAD. Now, if we just look at troponin results at baseline before intervention, we can actually see that most patients have quite low troponin. But after exercise, you can see that levels do increase by a small amount, albeit. But if you look at the number who are above the URL and the number below the level of quantification, you can see those levels do actually change quite significantly after exercise. So remember, half these patients were randomized to PCI and half to a sham procedure. So if we look at the patients with the sham procedure, we can see, as we would expect, just like the first set of results, really there's a change after exercise. But then if we look at the intervention arm, we can see again that there isn't really a huge amount of difference in the pre-exercise troponins between these groups, despite the fact they were revascularized. And also after exercise, both groups had troponin elevation. So it seems to be that exercise is increasing troponin, but it was unclear whether it was being influenced by other factors. So to try and provide more information and determine the most important predictors of troponin release, we constructed a Cox model. And you can see here that other than age, the only really significant predictor of troponin release was exercise duration. And we can again see that here in this plot. We can see overlap in PCI and placebo arms, and exercise time contributing the majority to the troponin rise. But what are the three key messages here? Well, first of all, troponin levels are common after exercise in all patients. Second, revascularization and resolution of that ischemic substrate doesn't appear to alter resting troponin levels. And lastly, the level of activity, rather than a level of ischemia, appears to be driving troponin release. So what does this mean for us as clinicians in clinical practice? Well, we know that troponin is an excellent biomarker of risk, not only in the acute coronary syndromes, but across the spectrum of acute coronary to chronic coronary disease, from whole population risk stratification through to patients who come to hospital with chest pain who do not have an MI, but also potentially in patients with stable angina. And the fact that these levels of this risk stratification marker are unaffected by the presence or absence of ischemia supports the relatively new paradigm that plaque characteristics and dynamic activity within the vasculature is more important in predicting risk than ischemic burden alone. And whilst we recognise that no biomarker would ever be able to determine exact percentage stenosis of coronary disease, our results raise the idea that rather than using ischemia to stratify patients, troponin could be used as a continuous biomarker of continuous risk to be able to select the correct patients for the correct test. Troponin results change dynamically, and combining that with risk factor profiles as well as imaging evidence of coronary disease could allow us to select the best patients and reduce the risk of doing invasive procedures. Thank you.
Thank you, Ryan. Bang on time. Right, questions from the audience, please. You've had lunch, you've had coffee. So, Christian, straight in there. I was traumatized by these data.
Perhaps I can help you with your trauma, or perhaps the answer that Ryan will provide.
Might make it worse, who knows?
Usually, I'm very jealous if I hear presentations from your group because you have an enormous size of study population, usually 40,000 sometimes.
48,000.
Now, you might have some challenges with your conclusion because this time you have a very small cohort and you might have overinterpreted the lack of effect of revascularization. Would you like to comment on the power in your study to detect the effect of revascularization or ischemia in general?
Yeah.
And perhaps on other studies that have tried to investigate the impact of ischemia?
I completely agree with the 198 patients. It's not a huge amount, but it's really one of the first studies which have measured biomarkers and tried to establish a role for them in competition with ischemia. And it gives some background and probably some evidence to why trials like FAME2, Courage, ischemia didn't show significant difference in outcomes because they were basing it on a test that really possibly doesn't matter. I think we also have to be aware as well that the patients who were included in the trial, they don't always necessarily reflect the patients in clinical practice. And most patients, well, all patients in Orbita had single vessel coronary disease rather than the typical patient we might see in the cath lab who has multi-vessel disease as well. Whilst no firm conclusions can be brought from this, I think that it does raise important questions that need to be investigated further.
Thank you for giving me the reassurance, Christian, that there's still hope. Now, if revascularization, I think we accept, reduces ischemia, but it didn't modify troponin in this population yet. Troponin's a phenomenal predictor of cardiovascular events. What do you think troponin is telling us in patients with ischemic heart disease about the future, if it's not to do with the presence of critical proximal LAD disease?
Well, I think there's a couple of messages from the data. Troponin can be released for lots of reasons, and it's probably being released from the vasculature because of oxidative stress, and whether that's through exercise, whether that's through inflammation, or whether that's through ischemia. And it's trying to pick apart all of that information in each individual patient, because clearly in your patient who's got no coronary disease, who's 24, and stressing them, their troponin goes up, well, it's clearly not because there's myocyte necrosis. So we're trying to pick apart that information. And I think that using models or using AI tools that combine risk factor profiles with imaging is probably going to be the way forward.
Okay, thank you, Ryan. I'd love to discuss exercise-induced troponin release with you for the rest of the afternoon, but we have another presentation. Thank you very much.